Next, Andrew Cha will talk to us about arterial and venous blood pressure in cardiac surgery-associated AKI.
Thank you very much, Luis. Good afternoon, everybody. My name's Andy Shaw. I'm an intensivist now in Cleveland, but until 3 years ago, I used to work between the last speaker and the next speaker, so I'm kind of an Alberta sandwich, I guess. I'm going to talk to you about blood pressure today. Here are some disclosures. None of these are related to blood pressure, particularly in the setting of heart surgery. But I'm going to talk to you a little bit about why I think, in particular, venous blood pressure is the forgotten soul of the problem, and try and illustrate why that is. So we'll talk very briefly about some physiology as it relates to AKI in the setting of heart surgery. We'll look particularly at the role of mean arterial pressure, and I'll try and make the case that mean arterial pressure isn't what you should be worried about. What you should be worried about is mean perfusion pressure. And then I'll illustrate using some data based around venous congestion principles and CVP about why I think MPP is the new MAP. So this is still, for my money, even after 8 years, probably the best cartoon that summarizes why patients having heart surgery get AKI. And the fundamental problem is it's a twin assault on the tubule. Just at the time when perfusion to the glomerulus is being reduced because of a number of things like cardiopulmonary bypass and hemodilution, hypothermia with a side dish of bleeding complications, just at the time that flow is being delivered, delivery of DAMPs and PAMPs to the tubule from both glomerular filtrate and also the peritubular capillaries is increasing. So just at the time when the kidney is most vulnerable, we increase the delivery of toxins to it, and then we scratch our head and say, why did the kidneys fail in a third of our patients? And so perfusion is manifestly important. The problem is we don't really understand why that is. For those of you that would argue that there are many, many definitions of acute kidney injury, let me introduce you to the intraoperative hypotension literature, where every time you write an article about IOH, it's traditional to invent a new definition. So at the time of writing, and this is now almost 15 years, God knows how many definitions there are now, but at the time of writing there are 140, of which the commonest is about a fifth or a 20% reduction from baseline. And in practical purposes, people talk about a systolic less than 80, or these days a MAP less than 60. That's what we mean by intraoperative arterial hypotension. Now, this is, in that same study, found a database of almost 15,000 patients. And intraoperative hypotension is so common, it is almost the norm. It occurs in more than 9 out of 10 patients. So you might look at me as an anesthesiologist and say, well, what the hell are you lot doing in the operating room? And I think that's a very reasonable question. The answer, of course, is the crossword. Now, 40% of patients in that study had systolic blood pressure less than 80, and this is a real problem. And a fundamental question, however, and historically, the perioperative community thought this was just a cosmetic problem. And then Dan Sessler and colleagues started to scratch their head and say, well, maybe it's not. Maybe it really is a problem. So does it matter? This is the Pokey group who put together this consensus meeting 4 or 5 years ago and wrote a series of papers in the British Journal of Anesthesia. And this paper in particular actually turned out to be the highest downloaded and cited paper in the BJA that year, suggesting that indeed it is a problem. And they went into causes and effects and potential treatment options. The consensus statement they came to was that an intraoperative MAP below 60 to 70, let's call it 65, is indeed associated with, but not necessarily causal, for both myocardial injury after non-cardiac and cardiac surgery, acute kidney injury, and death. And in particular, a systolic less than 100 is associated with both cardiac dysfunction and death. And the lower it is, the worse it is. Now, that shouldn't be particularly surprising, but it's nice that the literature supports what we have commonly believed. In particular, hypotension in the setting of tachycardia caused, for example, by maybe bleeding or other causes of hypovolemia is particularly bad. And as I'll show you in a few slides' time, for people with preoperative hypertension, the threshold at which harm occurs is almost certainly higher than just 65. So an absolute number is good for population work, but not particularly useful for individual case consideration. So if low blood pressure is bad for you, does it matter how you fix it? The answer is yes, it does. At least at the time of writing this study, there were at least theoretical reasons about using pure alpha agonists instead of volume to support blood pressure. We now know that over the course of the last sort of 10 years in the so-called dry phase of perioperative care, where we now give a lot less fluid, and we use more inotropes, we still see the same amount of AKI. It's just caused by a different problem. And I think this is because we have repeatedly failed to pay attention to the real determinants of perfusion across the two kidneys. And I'll talk a little bit about that in a minute. In terms of, well, what can we do about it? This is a couple of infographics from those two papers. And the first thing to do, and again, this might seem obvious, is don't send people to the floor if they're not ready to go to the floor. It sounds obvious, but happens especially these days because of production pressure. And if you find people on the floor who are hypotensive or tachycardic, move them to a high care environment. That's the first thing to do. And then pay attention to things like passive leg raising, assess patients for their volume responsiveness. And I'm not going to get into too much more about that because I think the physiology here is interesting. I love to show this slide about the Pravaki trial that Alex Zarbok's group conducted because it was a randomized controlled trial in the setting of patients at high risk for AKI undergoing heart surgery, single-center trial. And just to remind you, the bundle, which was tested in that study, was one looking at avoiding nephrotoxins, discontinuing ACE and ARBs, paying close attention to renal function and urine output, avoiding high sugar, and then considering alternatives that we've just heard to radiocontrast agents, accompanied with a large dose of hemodynamic monitoring, in this particular study using a femoral arterial thermodilution catheter across the heart. And they demonstrated significant reductions in all AKI, and in particular in moderate to severe AKI. Now, you may say 70% in the control group, that's an enormously high incidence. And the answer is yes, it is. But remember, all of these people had a positive nephrocheck going into this study. So the fact that the baseline rates are high is sort of what you'd expect. They demonstrated in the intervention group that patients got more dobutamine, they had a higher MAP, and they had a higher CVP, which I'm going to argue in a minute isn't necessarily helpful. But they did have a better oxygen delivery, less hyperglycemia, and less use of ACEs and ARBs. So the bundle worked. Now, that's a single-center trial. And so what Alex and Melanie Mirsch did was reproduce the trial in a Pravaki follow-up trial where they went multi-center, same size studies, same intervention, and this time only demonstrated an improvement in moderate to severe AKI in the intervention group. The overall incidence was the same. Nevertheless, here is a single intervention trial which worked, repeated and supported by a multi-center intervention trial of the same intervention, which also worked. And so you may say, well, which part of the bundle is important? And so the same investigators combined the two data from the Pravaki trials and came to the conclusion that apart from hemodynamic optimization, blood pressure management, paying attention to volume status, the other bundle components essentially appeared to have little or no impact. So if you believe that the AKI bundle in the setting of heart surgery works, as described by the Pravaki investigators, it's the hemodynamic stuff which is particularly important. All right, so if blood pressure is important, and hopefully you believe that it is, let's start thinking about if there's any evidence that focusing on blood pressure as a therapeutic target is effective. This is a trial in septic shock patients, not heart surgery patients, but it illustrates a nice concept. These patients were randomized to a high or a low blood pressure target for the treatment in the ICU of their septic shock. And you'll see from the arrows on the slide that in patients who were chronically hypertensive, both stage 2, or doubling of plasma creatinine, and stage 3, or dialysis, acute kidney injury, was significantly lower in chronic hypertensives who were managed with a higher target. Now, that shouldn't be surprising, but again, it's nice to show in the randomized double-blind intervention literature, sorry, not double-blind, single-blind interventional literature here, that cause and effect relationship appears to hold. This is the IMPRESS trial from Foutier and colleagues. This is individualized blood pressure management approach compared with a standardized blood pressure management approach in patients undergoing major surgery. And you can see in the blue boxes here, this is the individualized treatment. It's ever so slightly higher throughout the whole time point of the operation, which is around about 6 to 7 hours in this case. They demonstrated that the primary outcome in this trial, and this is why they got into JAMA, was statistically significantly better in the individualized treatment group. And the primary endpoint was some marker of systemic inflammatory response and dysfunction of at least one organ system. Looking at the renal-specific secondary outcomes, the improvement is numerically in the favor of individualized treatment, which didn't reach statistical significance, probably because at 300 patients they weren't powered to find that. Dr. Osterman, at the time, wrote an accompanying editorial, I believe, saying, hold on a minute, that a map of 65 seems to miss two very important points. As the ASFAR study demonstrated, inter-individual variability is very important. If you are a chronically hypertensive kidney, you don't sit quite as happily at a map of 60 when your normal map is, say, 110. And what about venous pressure? What about CVP, the other part of the perfusion equation? They actually followed this opinion up with a study looking at ICU patients who already had a diagnosis of stage 1 AKI and looked for progression to stage 3. What are the risk factors that are particularly important? And they demonstrated that a low mean perfusion pressure, less than 60, that's just the MAP minus the CVP, was associated with a 40% chance of increasing to stage 3. So that's important. Now let's think a little bit about renal perfusion. Now I'm a very simple airway doctor, right? So I think of perfusion issues as simply as possible. And when you are a fixed obstruction to flow, like a capillary bed in an organ, flow through you is determined by the input pressure minus the back pressure. And things that reduce the mean perfusion pressure are things like a low input pressure, a high output pressure, CVP, or in the setting of intra-abdominal hypertension, intra-abdominal pressure. And there's some evidence that this isn't just another crazy late Wednesday afternoon thought of mine. Renal edema, I think, is really, really underappreciated because it's very difficult to detect. It's probably true that acute venous congestion is actually worse for renal perfusion than acute systemic hypotension. And why is that? Well, remember, just like the brain, and you probably remember from medical school neurophysiology the concept of the Monroe-Kelly doctrine, the soft brain inside a rigid box with various different compartments that affect the pressure-volume relationships therein, it is exactly the same inside the kidney, which is a squishy organ in a very tight fibrous capsule. And before we get into that a little bit more, just remember that on bypass, the CVP is 0, or maybe even negative because of the suction, the vacuum that the perfusionists and the perfusion techs put on the venous drainage. So CVP on bypass is 0, meaning the mean perfusion pressure is the MAP. And that's probably why we get away with having a typical perfusion pressure on bypass of about 60 to 65, which is typical. Now, let's think about CVP a little bit, and particularly venous congestion. Here are 4 papers I'm going to very quickly romp through. This is a paper, again in the BJA, from a previous institution of mine, a group, almost all of whom were fellows, actually, which is nice to see, with a couple of surgeons thrown in for good measure. These guys, in the context of another trial, in statins, in fact, of CSA AKI, looked at the cumulative time that the CVP was above 12, 16, and 20, measuring area under the congestion burden, as they called it, and demonstrated a pretty clear dose response that once the CVP goes up up over 12, the risk of acute kidney injury significantly increases. Doesn't matter if it occurs before or after bypass, the risk is the same. Remember, on bypass, the CVP is 0. This is a very nice paper from John Prowl and Chris Kerwin and Ronaldo Bellomo, pointing out the importance for generation of renal edema on things that increase back pressure on the kidney. Remember, the kidney is a soft organ inside a tight, rigid capsule. So things that increase pressure inside the capsule reduce perfusion, reduce oxygen delivery. And this is a really nice paper, and I would encourage you to have a quick peek at it. This is a study in which the investigators actually measured the concept of the the pressure-volume relationship inside a kidney by implanting a Camino pressure bolt into the parenchyma and then increasing the pressure inside the capsule by injecting saline into the renal pelvis. And they demonstrated, just like in the brain, with a capsule intact at the top graph here, a very clear exponent relationship between pressure and volume. When you decapsulate the kidney, and this used to be a therapeutic intervention once upon a time, believe it or not, you'll see that the relationship between pressure and volume once again becomes linear. So I will put it to you that things that increase intracapsular pressure, like renal edema, increased venous back pressure, and intra-abdominal hypertension, are extremely bad for you, and that's why. So in summary, I hope to have reinforced the groupthink view that renal perfusion is a big deal. I hope to have introduced the idea that CVP has been historically underappreciated. We're coming out now, I hope, of a 2 to 3 decade period where everyone loved to slam the poor old CVP as not relevant. I think if you're a kidney, it's really relevant. And so for those of you that are interested in take care of patients, my advice is keep the map up and the CVP down. Thank you very much for listening.